And so what happens is you see a clinical outcome, patient getting better when you do something. And then you're like, what could the mechanism be? And then you chase it down online and you're like, oh, maybe that's it. Maybe it has to do with the fact that it's helping the mitochondria. When people's feel better afterwards, maybe that's the mechanism. It's possible, right?
Yep.
Any other comments on that?
Well, it's a lot of good things happening. And then you mentioned the probiotic piece. So that's going to help even more. So after we get someone on a killing protocol, there's going to be good benefits there. Your energy is probably going to get better just based on doing that. And then when you go to the next phase, if we're going to come into the gut healing phase, you're going to get even better then. So it's really fun for us to kind of paint the picture here of just how is someone going up, better. And you've just outlined how. So pretty cool.
They talked about it right here. They talked about in conclusion, the study showed this is BP stands for blueberry juice and probiotic exhibit a synergistic effect preventing the development and that's non-alcoholic fatty liver disease by protecting mitochondrial function, suppressing the damage of mitochondrial ultrastructure by reducing mitochondrial swelling, right? So mitochondrial damage by antibiotics, as well as we could do the same thing when we search, let's say, pesticides or heavy metals or mold toxins. So we know the gut plays a big role in one, helping to absorb those nutrients, but number two, also helping to have beneficial bacteria that modulate these this inflammation and mitochondrial damage as well.
Yep. Well said.
Excellent. Well, it's good. That's just a couple of studies. I mean, when we look at research a lot differently. So just kind of everyone there, we look at clinical outcomes in patients and then we chase them back to what the literature says. The problem is a lot of people who are clinicians, they'll look at the literature and then they'll try to then come up with a clinical decision based on the literature. And that sometimes is really hard to do because a lot of the PhDs and a lot of the research out there isn't necessarily clinically driven. It may be driven because someone has a PhD in this area and they're just studying that topic because, or maybe it's an NIH funded study, who knows, right? So we're looking at things that are clinically driven, not research driven because someone has decided to dedicate their life to this topic and this is the study they're choosing, right?
Now it's good that we can kind of pull out some studies to help back up what we're saying, but it's not like we go into PubMed to try to figure out exactly what we're going to do. The clinical stuff is really, that's where all the magic happens.
Yeah. And some may say we have a confirmation bias in how we look for these things, but we're not looking for it out of the blue. We're looking for it because we've seen clinical outcomes support something is happening in that direction. And then we use the data, the research to say what could be, if positive things are happening in this direction, A to B, what could be the mechanism of why that is. And so we kind of chase it backwards versus the other way around.
Yeah. And it's a blast. It is fun for you to pull that stuff up, right? Because, we get used to our methods, we get used to our results, but when you get to see in the literature like that, antibiotics causing mitochondrial damage, is like, oh yeah, I forgot. That's why we do this. We don't want people to get damaged.
And you get confident when you see things repeat itself clinically. You're like, okay, something's happening here now. What? So you're going at it with a lot more confidence versus like, hey, I think maybe, I've heard this. It's a hearsay kind of thing. No, you've seen it. You've seen it clinically.